Welcome to Malawi, the warm heart of Africa. Malawi is situated in the Central Africa. This is our second medical mission to Malawi. This time we're going to land in Blantyre. Blantyre is the second largest town in Malawi. This week we'll be working in Queen Elizabeth Central Hospital in Blantyre. The hospitality of Malawians never ends. It starts from the airport. We'll be taken through this terminal. This is the VIP terminal. This will be our working place for next week. Let's see what everyone does. This is our anesthetic. You look quite convincing with this machine.
I will need to work it out. I'm sure we'll be able to work it out. Okay. I'm looking for the common gas outlet in this. I turn on the oxygen here. Isoflurane is used. Oxygen, air. Connected. I'm not sure connected. Ventilator is here. The urologist wondering about the
The equipments are quite basic. These are made specially for third world countries where the electricity is unreliable. We need to figure it out how it works. Of course, there'll be some help tomorrow.
Patient outlet, patient return. So this is a cycle system.
There are a lot of patients planned for operations and they're waiting for us, and we can't hang around with these equipments. Look at this bed, it's old, but that's why you get here and you have to work with it. You can't be stubborn, you have to work with what you get.
These are turned inside out for safety, just for storage, otherwise you will break them.
Our surgeon's trying to figure out how it works. These beds, all the functions are gone, it's too old.
You look like one of the Pakistan border guard between India and Pakistan. Can you do a salute for us?
The makeshift cap.
Finally, we figured out how the machine and bed works. Ready for work tomorrow. Monday, the first day of work. We got 6 patients booked for today for urology operations. They've been waiting for a couple of years for these operations. Lack of equipment and lack of expertise is the main reason.
Can you ask him if he's okay to be in the camera?
No problem.
Thank you.
So when you wake up,
This is our first patient for TURP. This is our list for today.
When you wake up, you will have a catheter inside the bladder, which will stay till tomorrow morning or day after, and then you'll be able to go home. So for the first 3 weeks, be careful, don't lift any heavy weight, and then it will take up to 4 or 5 weeks before things go back to normal. Okay, so hopefully everything will be all right.
I'm a medical officer from Zom.
Good morning. This is our anesthetic technique.
Tony Lawrence.
Tony is going to explain us about this machine.
This is the helix machine. We can use the cylinder, we can use the pipeline. So in this case, we are using the pipeline oxygen.
Using the pipeline, yeah.
We can use the concentrator.
We don't need to use the concentrator. This is the oxygen concentrator.
The concentrator, yes.
Only for power failures we use it.
Yes.
Yeah?
If we are running out of piped oxygen, then we can use the concentrator. We always put it in the off mode, like the way it is. We don't switch it on.
We don't switch it on.
Yes.
Yes, it's a very basic draw-over system. Yes, that we're using. So we moved the Seco machine to that side. So for today, we'll have to make do.
Okay with that.
I think tomorrow we'll swap the machines so that we have.
Oh, it's a good experience for me to work with this one
But
as well.
he's used it before. They were using one vaporizer, isoflurane.
Isoflurane, yeah?
If anything, he has my number. Yeah, no, that's
That's the
true.
plan.
Okay,
Thank you.
thank you.
This is the basic drawer machine,
Yeah.
in which the patient will be, if the patient is breathing
On his own.
on his own,
Yeah.
then you don't need to switch it on.
When the patient breathe, this glass
The
will
bag
move,
will
right?
show
Yeah.
the patient is breathing.
Yeah.
But we will switch it on when we want to put the patient to the ventilator.
Oh, okay. So you
So,
switch it
we
on
switch
only
it
to
on.
ventilator, yeah?
Now it will start ventilating
I understand, yeah.
the patient.
So it automatically ventilates.
Yes. So you,
What volumes you set at?
you set on the rate
Yeah.
and also the trigger.
And the trigger.
So the trigger, you can put the trigger at 4, you can put it at 5.
Trigger
No problem.
4,
Yes. So on the rate, depending on the age, you can put it at 14 or 12 if it's an adult.
And what volume will it give?
Adult is around by 350, 400 or 450.
So for children, what, you just increase the rate.
Yeah, for children, we just increase the rate because the lung capacity of the child, even if we increase the tidal volumes, the capacity of the lungs will still accommodate what the lungs can accommodate.
So this will give only what the lungs can accommodate.
Can accommodate for the kids.
There is no monitor where we can what volume we are giving. We just look at the chest expansion, I suppose. Filling up isoflurane. Look at that. I can smell it.
Yeah.
It's working. My camera can smell anesthetic gases. Oxygen?
Yeah, this is oxygen.
Air as well?
Yeah. This is where we set our tidal volumes.
Oh, you set the tidal volume there.
Yeah, you can still drop it down depending on the age.
So you drop it down depending on the age.
At 500.
Fantastic, simple ventilator. So you have two signs. The bag moves
And the
and the
ventilation
vent moves. And this is the patient.
This is the patient, yes. So the patient is breathing in and breathing out. What we have here?
We got the basics of the basic drugs here.
On sit down, but I think you need to check on that theater.
Do you have propofol?
Offer is out of stock.
Thiopentone? You have only ketamine.
So this is ketamine.
Adrenaline perform.
Adrenaline, 1 in 100,000. We have atropine.
Yes, we have. This is ephedrine.
And we got cannulas. Yeah, that's good. You got some syringes.
Okay.
Anesthetic team.
We are going to do it from this side.
So on, yeah?
Yeah, just a moment.
Okay?
Can we do a white? Have you done the white balance?
White balance?
Yeah.
Dextrose running.
I'm Bruno, an architect student. So we are here to do
Transmural resection of prostate. Bruno, have you seen this operation before?
This is my first time.
Spinal anesthetic.
I'm Duncan Koche, one of the clinicians from Zomba, working in the urology department. So we're conducting these operations, and our first case for today is Mr. McDonald, who has got a enlarged prostate for TRP. As of now, people are getting organized to start the operation. Today, I hope I should at least do one case for of TRP.
I'm Joy Henry. I'm a nurse.
Yes.
Never been in urology theater, so I'm learning, and it's great.
Yes. Now it's no longer.
This is Iqbal.
Yeah, hi.
Chico. Hello.
Eunice.
My Nkumba, from a medical officer from Zomba Urology. I'm really excited for this opportunity. There's an opportunity to get a scholarship to start my studies. That would be really great.
If you have a chance to train somewhere else, what will be your motive afterwards?
I will have to come back here, also practice here, and also help to nurture the other Malawians, also to get trained here in Malawi, so that we increase the number of people helping people with urology cases in Malawi.
Yeah, well, but I'm Dr. Olangwa Chisenga. I'm a urologist based at Zomba. I'm the only urologist in this region, so 2 urologists in the country, for a population of 20 million people. If we talk about half the country, about 10 million.
10 million?
Yeah, pretty much.
So you are the urologist for 10 million people. That is a big massive. What would you like to see in 10 years in the aspect of urology?
The most important thing is capacity building, training, more urologists trained. The interest is there. The main issue for us is to get some support and scholarships for the
Are you looking for some kind of collaboration, a long-time collaboration with a partner, so you can have a regular train?
In fact, we're looking forward to continued collaboration with the MAC and any other partner to support us, the training and also the exchange visits. And there's also a dire need for equipment.
You're also looking for equipment. What kind of equipment?
Prostates, a complete stack, the electrocautery machine, the telescopes, the resectoscopes.
Do you have flexible and rigid uroscope?
No, I don't have.
You don't have?
I know how to use them, but I don't have.
You don't have them.
If you don't have the right equipment, if you don't have the right accessories, and you know that this patient needs this, and if we were to do this, we would have saved their life and changed their quality of life. It can be quite depressing sometimes, just watching.
Watching, you could see what you could do, but you can't do it.
So these are patients that have been waiting for years.
So for 1 year, your telescope didn't work, so you suspended all the operation.
Suspended. Couldn't do cystoscopies for the bladder cancers, and there are a lot of them in my ward packed. But
you have the training, capacity, ability to do it, but you can't do it because you don't have that small right equipment.
Yes. So when it comes to urological cancer, we are seeing quite advanced cases. A lot of prostate cancers, a lot of bladder cancers, especially squamous cell carcinoma, penile cancers, delayed presentation. So they come very advanced. Most of the simple things like testicular torsions being missed periphery.
If you think about collaboration,
capacity building, so the training ongoing. So the collaboration would be very important. Equipment, minimal invasive equipment. Dr. Wanangwa Chisenga.
Justice Mapondo, anesthetist.
We finished the first case, 35 minutes. It was a TRP for chronic urinary retention with a long catheter for more than 3 years.
catheter was for last 3 years. Can he come off catheter now after the operation?
Keep him overnight with irrigation and possibly remove the catheter tomorrow.
So after 3 years he can have catheter free and he can have a normal life?
I feel good operating on the patient so that they should change their life. Eunice Banda.
My name is Steve Chamuruga. My scrub is
You are the recovery nurse. So this is going on in the background, the fantastic work of you guys. Look at that. Oh, cleaning the theaters and getting ready for the next case. What's your name?
Miriam.
Miriam?
Yes.
Oh, thank you very much, Miriam. What is inside the pillow?
We're making a pillow for the patient.
Patient, yeah.
Just to prevent high spinal.
Yeah.
Yeah, so we keep the shoulders up.
Shoulders up. Fantastic. What are you doing there? Oh my goodness, man. What is that?
Yes, I'm putting 10% dextrose here.
With 5% dextrose?
Yes, for irrigation.
So increase the pressure by lifting up the height, yeah?
Just improvising.
Works. Anesthetic.
Sorry. Yes.
How many months have you done?
I've done 9 months.
9 months?
Yes.
So this is our second patient. What is your name?
Abati Kanchevera.
Abati Kanchevera.
Kanchevera.
And he agrees to be on the film. And this is our team, anesthetic team. Scrub nurses getting ready, surgeon sitting. So this is the anesthetic technician trainee, 9 months into his training, and he's going to show us a spinal. But guys, obviously, I mean, if you are from the West, you might be thinking why they are not using gowns, they are not using all these things. But here, resources are limited, right? So they have to work with what they have. Gowns are limited for the surgery, and they don't have excess gowns for anesthetists or people who perform spinals. I never heard from them any infections or anything. Okay, cleaning his hands. That's not bad. So we need to shake this. Oh, you get the foam on the top.
Yes.
Fantastic, look at that. Ready?
Yes. Get one good in it.
That is a cleaning spirit, yeah?
Okay.
Yeah, don't worry. It'll work. To the patient.
Start again. Don't push further, just a bit. Yeah, it's okay.
Yeah, it's coming. It's coming. Stop. Good technique. It's coming out.
Yes.
Can you tell me where is the water now? Percussion. Wow.
Eunice is expert. Yeah, she has become.
Eunice is expert, yeah.
Stasis, so that I can see properly what's happening. Yeah. So they're not really going on one side. It's very tempting to go to the other side, but it's important to. This is the Vero Montano. The left lobe, yeah. Tissue around.
Sort of skeletonized the Vero mountain.
They need our support and encouragement to get through this and get more doctors trained and more medical staff trained in the specialities so they can cure, they can help their own population.
So urethral stricture, the common thing is sexually transmitted disease. It can be due to infections, it can be due to trauma. So that's now you can see that it cannot pass because there's blocking the passage. It's not passing because blocking the passage. There's another condition where there's no blockage, but patient is unable to pass urine. What can it be? Yes, no, neurogenic. So what happens is sometimes there's a thing called hypocontractile bladder. So the bladder loses its capability of contracting. So imagine you're standing in the toilet, this is relaxed, the passage is open, but this is not contracting. So patient is unable to pass urine. Usually when the bladder is weak, when it's not contracting, the patients are not in pain. They are in what we call in chronic retention of urine. When they come to us with a lot of pain, that is an acute retention of urine, and it is painful retention, that is usually due to the outflow obstruction.
I'm asking the wider world, the able bodies, organizations to come out with a collaboration with these doctors, with these hospitals, to train them and to empower them so they can provide a better medical health for their patients. Thank you, Malawi, for your hospitality and the great time we had together.